Good evening, everybody, and welcome to Icon Cancer Centre's Facebook Live event. Tonight, we'll be talking about breast cancer. And we're very lucky tonight to have three fantastic guests who are all international experts in breast cancer here to educate us. For those of you who haven't watched any of our series before, my name is Ian Irving. I have the privilege of being Icon's Chief Medical Officer. I'm actually a practicing haematologist at Icon Wesley and Icon Mackay in Queensland, Australia. So breast cancer is certainly not my area of expertise, and I'm looking forward to learning about some of the new advances and treatment changes in breast cancer from our three experts. Tonight, as always, please, if you have any questions for any of our panelists, please enter your question through the chat. We'll try and get to as many questions as possible in the second half of tonight's event. Also, of course, there will be a recording of tonight's event put on the Icon Cancer Centre YouTube channel, as well as a link appearing on the Icon Cancer Centre website. So if you've missed tonight's event live, or if you wish to share tonight's event with a family member or friend or colleague, people have access to be able to watch the event through those two channels. So before we get straight into some questions for our panelists, I'm just going to introduce our guests. Firstly, tonight we have Professor John Boyages. John is a Sydney-based radiation oncologist with Icon Cancer Care. He's an international expert on breast cancer as well as lymphedema. He's an acclaimed author, having published many books, with his latest book, Breast Cancer Taking Control, the second edition, only coming out on Amazon within the last couple of weeks. John, thank you very much for joining us tonight.
Thank you.
Secondly, we have Associate Professor Louise Nott. Louise is a medical oncologist at Icon Cancer Centre, Hobart. She's a very experienced medical oncologist, running numerous clinical trials at Icon Cancer Centre as well as Royal Hobart Hospital. Breast cancer is one of her areas of expertise, and Louise is going to speak to us tonight as our resident medical oncologist. Thanks for joining us, Louise. Thanks. And thirdly, and definitely not leastly, we have breast cancer care specialist nurse, Anne Retzlaff. Now, Anne is a very accomplished woman, continuing to work as a cancer care coordinator, a specialist breast care nurse, and also as a midwife, running antenatal classes in her spare time. She works in both the public and private sectors in Perth, Western Australia, including Icon Cancer Centre, Midland, and Anne's expertise, experience, and very different take on breast cancer will be informative for all of us. So welcome, Anne.
Thank you for inviting me.
Okay, so firstly, I will go back to you, John, and ask you if you could talk to us about radiotherapy for breast cancer. When is it used, particularly in early stage breast cancer? How is it delivered, and what have some of the recent changes been for radiotherapy in breast cancer?
That's a big question, Ian. Look, first of all, radiotherapy uses carefully targeted X-rays to kill off any tiny cells, microscopic cells, that may remain after surgery and therefore reduce the chance of cancer coming back. Now, traditionally, there's two approaches in breast cancer. One is called breast conservation, where a surgeon removes the lump. We call that a lumpectomy, and then we give radiation after that. And in my book, Breast Cancer Taking Control, I describe the breast like a rose bush, and under the breast there's a weed. Now, the surgeon decides with the patient, do I use my small spade and lift the weed out with some healthy soil around it? And then my job as a radiation doctor is to put a weed mat or weed mulch down, and that stops the seeds from growing back. Now, If there's lots of weeds under the rose bush, in many places, the surgeon may not have any choice but to remove the whole rose bush, or that's called a mastectomy. And then in certain situations, particularly if the cancer is large or if the cancer has spread to the lymph nodes, we would also add radiation therapy. These days, radiation takes about 3 weeks. In general, it used to be 6 or 7 weeks. And for some patients, we can do it as short as 1 week. And we have certainly some patients come into our centre. They might stay at Sydney in the Wahroonga, in Jacaranda Lodge, stay there for a week, have a course of radiotherapy. With Icon, we've seen such investment in new technology, and the radiotherapy I'm seeing today is the best I've seen in my 40-year career. We can sculpt radiotherapy and shape it. We can reduce the doses to the heart by using techniques called deep inspiration breath hold, which simply means the patient takes a deep breath for 20 or 30 seconds, and then that moves the heart out of the way and reduces the doses to the heart. We've also developed amazing surface-guided software that replicates the shape of the patient every single day, and means we don't have to use those awful black tattoos anymore, and that's obviously a lot better for the patients. Now, lastly, the hardest part about radiotherapy today is sometimes it's a line ball decision. Do we give radiation therapy or don't we? And in the part, so today, if someone has one lymph node, uncomplicated, we may not give radiotherapy. There's been new trials showing that with the latest immunotherapy or targeted therapy and chemotherapy, if a patient goes into complete remission, we may not need radiotherapy after a mastectomy. And lastly, we sometimes don't need to treat the whole breast anymore, and we're lucky that the Icon Foundation has funded a study that I helped design, where we're giving radiation just to a small component of the breast after that lumpectomy, and that's we give the treatment over 1 week, and I've treated over 100 patients like this off the study, and they're hard to get any symptoms. They just come in, has to be early breast cancer, node negative, and they come and go, 5 treatments, and when they come back and see me 6 weeks later, had no side effects. Thank you.
No, that's great. And what an advance in radiation oncology, getting rid of the tattoo marks. Is it universal, John, that those tattoo marks are never used, or is it only in special situations that we can do radiation therapy without the tattoos?
Look, I'm not sure across Australia how many people are doing it without tattoos, but certainly in our breast cancer world, in Icon, most of us have moved away from tattoos. And I remember when I used to work in the public hospital, 100 years ago, that patients would be given 6 tattoos, and there'd be one right here where women would wear their necklaces and things. And I used to argue with them and say, look, at least get rid of that one, but no, and people were marked, and some people would use laser to get them off, or would even use surgery to remove them. But these days, we don't need them in most situations.
Right. No, that's great. And the shortened course down to 5 fractions, is that only for the early stage breast cancer when you are doing partial irradiation, or are there other situations where you can only use 5 fractions or 1 week of treatment?
Look, there was a big trial from the United Kingdom. It was called the Fast Forward trial, and that compared 15 treatments of whole breast radiation to 5 treatments of whole breast radiotherapy. So there's accelerated whole breast radiotherapy and accelerated partial breast radiotherapy. And more trials are now exploring whether we can give that to wider areas and include the lymph nodes. That worries me a bit. I think I'd like to see a bit more data, because we've got very precious nerves in the neck and so on. And I'd like to see longer follow-up before we do that. But at the moment, if someone's definitely over 50, sometimes over 40, with a tiny breast cancer, less than 20 millimeters, node negative, no family history or genetic abnormalities, we can give partial breast irradiation.
Right. No, thank you. Very illuminating, John. Louise, breast cancer is clearly a huge topic, and breast cancer is really made up of lots of different diseases, and this is happening with all sorts of cancers these days, where they're getting split up into subtypes that are treated sometimes very differently. Would you be able to, Louise, tell us about the different types of breast cancer and how that affects the sort of medical oncology treatments that you give patients?
Yeah, thanks, Ian. There's just been a huge advance in our understanding of the biology of breast cancer. And you're right, you can have two patients with breast cancer, but they're completely different and their treatments will look very different. So I guess on a basic level, we're looking at the biology, the breast tumour, looking for some proteins. I think most of the audience would be aware of estrogen and progesterone, whether they're present, and then HER2 protein overexpression, which is even the way that we look at that has changed just in the last little while. It used to just be if people had very high level of HER2 expression, we would call that HER2 positive breast cancer. But now we're looking for even just a tiny bit of HER2 expression, and we call that HER2 low. If we don't see any expression of estrogen and progesterone and HER2, we call that triple negative breast cancer. But we're even understanding more about that and new biomarkers. So I guess we look at all of those things, and as a result, our treatment conversations with patients become more and more complex, which is good in many ways because we really personalise the treatment, and we have so many different treatment options based on the biology of the cancer, I guess the stage of the cancer, whether it's early stage disease or advanced stage disease, and then the patient in front of us, what matters most to them, their age, their other medical problems. So I guess when we sit down with a new patient, we usually have an hour session, but it's hard to kind of get through all of the different options these days, which is great. And often we need to get the patient back. So complexity is good in terms of more treatment options, and we're understanding the biology better so that we can personalize the therapy. And also in medical oncology, as John alluded to, we're trying to escalate therapy where it's important, where we have a disease or a cancer that's, very risky, has a high chance of causing problems, and then de-escalate our treatments when, the cancer has less risk of progressing or coming back. So a lot of stuff's happening, which is really fantastic for our patients.
Yes, absolutely. And the outlook's so much better, which is great. We hear a lot in the media about genetic testing, Louise. And obviously we can send the breast cancer samples of patients away for genetic testing, and there's various different labs that offer these services. When do you utilise genetic testing in breast cancer?
Yeah, that's a really important question. And thankfully, after many years, I guess, of lobbying the government, we do have availability of what's called germline testing. So that's the testing that we generally do on the blood or on a saliva sample to try and identify women and men at higher risk of developing breast cancers. And they are the kinds of genes that might be, I guess, handed down from generation to generation. So it's important that we are able to find those abnormalities in patients and families. Those genes are now expanding. It used to be just BRCA1 and BRCA2, which people might be aware of, but now I think the panels have 13 up to 20 different genes we're looking for. And we can, in many cases, get those through the Medicare system, which is fantastic. It's funded for patients. So almost all of my patients with breast cancer, I'll be having that discussion about what that means and whether they would like to have a blood test or a saliva test to look for those particular genetic alterations. I think in addition to that, we can also look for alterations within the tumour itself, and they're called somatic gene abnormalities, and they, I guess, can sometimes be helpful to guide treatment, particularly in advanced breast cancer, or they might provide us with some information about the risk, so the risk of the cancer coming back or the potential benefit of certain treatments like chemotherapy. So we're really applying that genetic information and knowledge and testing, I guess, much more routinely in our practice these days.
No, which is great. Thank you for that explanation. I'm sure that'll be very clear for people. And over to you now, and looking into some of these treatments for breast cancer, as Louise says, treatment has improved no end, and also, of course, survival rates have improved as well. But with all medical treatment, there are potential side effects, unfortunately, even if they're less now than they were in the past. Do you want to go over some of the common side effects of treatment? I know that's a big topic in itself, but going over the common side effects and focusing on the ones that you and your patients find most important and problematic to them.
Yes, thank you, Ian. Yeah, you're quite right. There is potential for side effects with just about everything that we do. But whether someone will get side effects or, in fact, what side effects they're likely to get, lots of factors go into that. As Louise was talking about the different kinds of breast cancer, obviously different kinds of breast cancer require different treatments, and that can affect the side effect profile, as can, you know, someone's age and other comorbidities. But some of the most common side effects we do see are maybe post-surgery, things like lymphedema, cording or shoulder stiffness, or swelling. And with some of our other treatments, we're likely to get things like fatigue, and it's really important that the people are very fatigued from their treatment, try to get rest. Exercise is a massive change in the last 5 to 10 years. It's really a really good idea to have or be linked in with an exercise physiologist, eating a good diet, avoiding caffeine and alcohol. Some of our hormone blocking treatments in particular can cause things like sexuality and intimacy and menopausal type symptoms, such as vaginal and genital dryness, thinning, pain during sex, increased risk of urinary tract infections, lower sex drive, hot flushes, insomnia. So a lot can be done for those kind of side effects, but people tend to not want to address those as much with their treating team as what they should do. So it's really important that people discuss this with their oncologists, their breast care nurses, because their oncologist can prescribe medication. We can refer them to clinical sexologists and menopause after cancer clinics. Exercise again is really important for this kind of these kind of side effects. Balanced diet, staying hydrated, and things like the use of vaginal moisturizers and silicone lubrications and things like that. But it's really important to have a really robust discussion with your treating team and get referred to the correct resources. Other things are cognitive issues. It's quite common to get what's known as potentially chemo brain, so that's not uncommon. So it's really important to get some good sleep and once again do that physical activity. And of course, while physical side effects and symptoms are fairly common, there's also quite a lot of psychosocial side effects like anxiety, depression, or scanxiety, you know, when it comes time to rescan and things like that and follow up, you know, because you get followed up for a period of time after a breast cancer diagnosis. And it's really common for people to get fear of cancer recurrence. They can often feel socially isolated. They can have body image issues related to the fact that they might have had a mastectomy, and they might also get financial toxicity where they're unable to work as much as they did, but the costs of their cancer are actually quite high. So the things we can do, of course, are to refer for professional therapy, refer them to peer and group support, and we can also discuss with them things like mindfulness, meditation, exercise. I know I've mentioned that a few times, but it really is a body of research that is really gaining quite a lot of traction and quite a lot of research behind it now, and things like yoga and Pilates and things like that can help also.
Sure. No, thank you for that. As you say, it's a huge area, and obviously the work you do with patients with breast cancer is very broad. When you mentioned the hormonal issues and also problems around intimacy and sexual function, do you think these are being brought up with you more commonly now than in previous years? Are these sorts of issues more out in the open, or do you find you do have to coax them out of people during discussion?
I think it depends, and I think it depends on the age of the person, their social background, their psychological background. I would say that they're being brought up more commonly than when I first became a breast care nurse in 2013, but I don't think they're being brought up as often as they should, and they can frequently cause really significant quality of life impacts for both an individual person who's got cancer, breast cancer, but also their intimate relationships.
Sure. Yes. No, I think that's one of the things we try to aim for with doing this broadcast every 2 or 3 months is shining a light on areas that potentially are overlooked in the mainstream coverage of various topics relating to cancer. So, no, thank you for bringing that up. You also mentioned, of course, diet and exercise. Now, when it comes to cancer and diet, it seems that everyone has an opinion, particularly modern day influencers, but also well-meaning family members and friends, and they'll have a diet tip for the person undergoing chemotherapy or radiotherapy, and it'll sometimes involve some unusual supplements, various things. I won't name it. They go in fads. What do you tell people about a diet, and what advice do you give people around supplements and alternative health type remedies?
I think John and Louise would have a lot to say about this, but I tell them to eat a well-balanced diet. That's the most important thing. No crazy diets, no antioxidants or anything like that for lots of good clinical reason. And I also do tell them the difference between the Living Well with Cancer programs that the Cancer Council and Breast Cancer Care can provide, and the difference between that and exercise physiology. Because certainly with a lot of cancers, and certainly when we're blocking a lot of hormones, someone's bone density can be certainly impacted, and things like fat cells and that can also release aromatase, which then gets converted into estrogen. So that can feed those estrogen-driven cancers. So yes, balanced diet, exercise, and trying to keep a healthy weight is important.
Right. Anything you'd like to add to that, Lou, on
I
diet
think
and exercise?
Anne's done a good job at kind of covering those things. I guess a few things when we're talking about diet. I mean, as Anne mentioned, cutting down alcohol. We know that unfortunately alcohol does increase the risk of postmenopausal breast cancer and many other cancers as well. Kind of heavily processed food, like heavily processed meat and that sort of thing. We try and reduce that, very sugary things, which is usually in that heavily processed thing. So whole foods, more vegetables, nuts, legumes, and we sometimes call that a Mediterranean diet. But, I guess it depends on where the patient is and what stage of cancer. And as Anne was saying, in women that go through menopause, and as a menopausal woman, I know all about this, we are talking more about it. But, weight gain is an issue. So sometimes we're having to look at the type of diet, and we really need to get a dietitian involved and also an exercise physiologist, because, women don't want to put on weight during their treatment. But obviously, if a patient has advanced breast cancer, we're trying to, increase the protein to reduce muscle wasting. So it is quite complex, and I think getting a dietitian to help our patients and guide them as to what the most appropriate diet for them is during whatever phase of treatment or whatever stage of disease is really important.
Right. No, thank you for that, Lou. Now, while we're talking about side effects, and Anne certainly went through a bit, John, a particular side effect that does occur sometimes, and you are a world-renowned expert on this topic through your research and also through your education and treatment of the condition, is of course lymphedema. Do you want to explain to our audience, please, John, what is lymphedema and when does it occur and how is it treated?
Again, a big question, but simply we've got lymph glands all over our body. They're part of the first line of defense. So for germs or cancer, infection. So when we get a sore throat, often our lymph glands or lymph nodes in the neck are tender. And in cancer, we know that breast cancer can spread to the lymph nodes under the armpit, and we often need to do small surgery, that's called a sentinel node biopsy, or more extensive surgery, that's called an axillary clearance. And the more we damage those lymph nodes with surgery and the added effect of radiation, it's a bit like putting rocks in a river. The river banks up and the river slows down, it can be dirtier, it can overflow into the surrounding paddocks and get all mushy. And that's what happens with some patients, not all patients. In fact, very few patients these days get chronic lymphedema. It's important to look for it early. If you notice your rings getting tight or some swelling in your fingers on the back of the hand, or it just doesn't feel like right, see your doctor or get referred to an accredited lymphedema therapist. They've got some fancy machines called bioimpedance, the SOZO device, that you can jump on. It's like a scale. They can quickly detect if there's what's called subclinical lymphedema, which is a bit like finding a small cancer on a mammogram. We can't see it, but the device can detect it. So early detection is important. Treatments, the earlier you get it, the better. You can reverse it in some cases. But if it's established, you may need bandaging, compression garments, massage, skin creams. Weights can make it worse. And but the really important thing is make sure you are aware of it. If you're at high risk, and in my book that I published last year, Lymphedema Taking Control, there's a whole table of what's at high risk, what does that mean, how often you should be screened, and the sort of precautions and the do's and don'ts. But yeah, probably a bigger topic for another day. And I think we've got a previous video on that as well.
Yes, I think we did. It was a few years ago now. We did a whole session on lymphedema.
Actually, can I just mention something about alcohol? A lot of my patients feel really, they look up on the web and they say you can't drink alcohol and it causes breast cancer. But when you look at all these risk factors of breast cancer, it's like this complex Rubik's Cube. There's, genetics, there's lifestyle, there's environment, alcohol. These are all minor risk factors in the scheme of things. And I think our patients, really scared of recurrence. They've told to their whole body image is affected, and certainly I don't have a no alcohol policy, and I don't think Louise does either, Lou does either, but I say, look, average of 1 a day, that's 7 a week. If you've got a function on Friday and Saturday night and you want to have 2 or 3 on 2 days, that's fine too. And I think we've got to be careful not to make everything bad for the patients, and give them some pleasures of life.
Yes, no, quite true, and that's right. Moderation's important, and as you say, a few alcohol-free days a week important. But no, it's a good point, John. Lou, we're going to go into audience questions soon, but before we do, just a question again for Lou and then Anne. And please, to everyone watching, if you have a question for any of our panelists, please put your question in the chat. We'll get to as many as possible, but those that we can't get to tonight, we will attempt to answer through the Icon Cancer Centre Facebook page and website, so that you'll get an answer to your question. We're definitely giving information only. This is not detailed personal medical advice. Now, going away from side effects now, we all mentioned, I think, in our introductions about how much better treatment is now compared with even 10 years ago. Lou, do you want to outline a couple of the most profound changes or profound new treatments that have come into practice for breast cancer, please?
Yeah, of course. So I guess when we're thinking about treatments, I tend to divide them into groups. So targeted therapies, immunotherapies, this new class of drugs called drug antibody conjugates, and then, kind of other. But if we just think about targeted therapies, in the last kind of, I guess, 5 years or maybe a bit longer now, the really big difference that I've seen is in the treatment of estrogen receptor positive breast cancer, particularly advanced estrogen positive breast cancer, and now early estrogen positive breast cancer with higher risk features. We're using these drugs called CDK4/6 inhibitors. They've all got really long names, so abemaciclib and ribociclib and palbociclib. And they are used in combination with more commonly known endocrine therapies such as aromatase inhibitors. And they have absolutely changed the way we treat advanced breast cancer. We used to have a lot of women coming in for chemotherapy, and I remember those days. And nowadays they take some tablets with advanced breast cancer for hopefully many years before we need to change therapy. And even when we do, there are new classes of drugs where we can understand why the cancer is becoming resistant, and they've developed kind of specific targeted therapies against whatever that particular abnormality might be, whether it's a PIK3A mutation or an ESR1 mutation. All of these, amazing drugs are being developed. And I guess the other kind of area that's really changed things is these drug antibody conjugates, which are I think of them like Trojan horses or smart chemo. It's where you have an antibody that is attached to a chemo, usually a really kind of potent chemo. And then if you've got the appropriate kind of breast cancer, so for example, if it's HER2 expressing in any way, really, even if it's a low HER2 expressing, we can use this drug called trastuzumab deruxtecan, which basically takes the payload of that very strong chemotherapy to those HER2 expressing cells and deposits that chemotherapy within the cells, and therefore kind of reducing the side effects that the patients experience. I'm not saying it's not like chemo. There are some chemo side effects, but those chemotherapy side effects are reduced, and these drugs are highly efficacious. So I think that's really changed the way we treat many of our breast cancers, and in fact, lots of cancers. And then finally, of course, immunotherapy, which a lot of people are aware of, and we do now have, I guess, a broader access for immunotherapy in Australia, but we predominantly use immunotherapy in certain patients with triple negative breast cancer, and it is really important, obviously, to find new treatments for that group of patients, and it's great to see these new treatments emerging that are improving outcomes for patients. So they're the main big groups of, I guess, drug advances that I've seen in the last little while.
Right, yes, it's become so complex and to treat any cancer these days. And as you mentioned, antibody drug conjugates used in a lot of different cancers now across medical oncology and hematology, and that targeted therapy, very exciting. And when we last spoke to you a few minutes ago, you did outline a lot of different side effects in patients who are treated for breast cancer, and which was very illuminating, and thanks for doing that. Of course, as we go to our questions, and we have got a few questions coming in that I'm looking forward to getting to in a few minutes, but to take that talk about side effects and put a positive spin on where can people go to get help? How can what is done, and who can people turn to alleviate some of these side effects of breast cancer itself and the treatment, and therefore keep as best the quality of life as possible during treatment and, of course, after treatment?
Yes, thanks, Ian. So obviously the main resource that people can go to is their oncologist, their medical oncologist, their radiation oncologists, and also various allied health team members. So it's very common these days to treat the whole person when it comes to specifically breast cancer in this case. And so we quite often use, and sort of the oncologist will also utilize dietitians, physios, lymphedema therapists, GPs, and of course exercise physiologists. But of course, there's also community resources such as tumour-specific organisations. Over here, we've got Breast Cancer Care WA, and they do have tumour-specific organisations in each of the states. Cancer Council as well. Each of the states have their own branch of the Cancer Council, and they can help provide things like counselling, financial counselling, pro bono legal, and of course the Living Well and the Life Now programs that are so important for people's social health, but also their physical health. And of course other organisations are MBC Action Australia, which is for those women who have got metastatic breast cancer diagnosis, meaning that it's getting managed and for the long term and not cured. The Australian Survivorship Centre, there's an awful lot of focus now on survivorship, because obviously side effects can be the short term or they can be long term, whether that is psychosocially, mentally, physically. The McGrath Foundation have a lot of cancer support coordinators, breast specific as well as non-breast ones, and of course your cancer wellness centres, such as over here we have Solaris Care, and they help with things like meditation and music therapy and art therapy and mindfulness. For women impacted by breast cancer who happen to have children who are going to be experiencing a cancer diagnosis indirectly, we've got Cancer Hub, and that makes up, that's made up by Red Kite, Camp Quality and Canteen. Rare Cancers Australia also have Mummy's Wish, and that helps people with very young children under about 6 or 7. And then of course things like menopause after cancer clinics, which exist in each state as well. So there's lots and lots of support out there.
Great, thank you for that. And it is just so wonderful to have so many groups now that have developed and sprung up across the country. No, thank you very much, Anne. Going to our audience questions now, and thank you to everyone who's submitted a question, and please keep your questions coming. This first question, I'll direct to John, but anyone else who wants to make a comment, please do so. The question is, John, how common is breast cancer in men? And I don't just put this to you because you are a man. I really put this question to you, of course, because you have published a book on male breast cancer. And so I think you're probably one of the country's leading experts on the topic.
Yes, look, male breast cancer, it's about 1% of all cases, and I'm trying to remember how many in Australia, but it's around 200, I think, a year. So it's not very common, and it's often missed, and often it presents with a lump on just beneath the nipple. It's hard. It feels more like the tip of your nose rather than, say, your cheek, which is soft, because men do get man boobs from perhaps obesity in general, or drinking too much can increase the estrogen levels and cause the breast to enlarge in men. So it's important to, men can check their breasts. If there is a lump, insist on an ultrasound and possibly even a biopsy. Treatments generally the same but different, and there's some quirks to it. Important thing is probably easier to read the book, get the online book and read it, because it is a bit tricky in some circumstances. Right.
Yes. No, thank you, John. Have you treated many male patients with breast cancer over the years, John and Louise?
Well, yeah, I mean, many. Bilateral. At one stage, I had a man and his daughter being treated at the same time.
Right.
You know, he was being treated, and then his daughter was diagnosed a couple of weeks later. And obviously, in that situation, as Louise said earlier, you've got to think about the genetics. You know, the breast cancer gene 2 or the BRCA2 gene is often associated with male breast cancer, ovarian cancer, and so on.
Yeah, I think that would definitely be a reason to offer genetic testing. And I think it is challenging for men as it is for women, but often men are very worried about, because often their tumours might be estrogen positive, and, having that discussion with them about estrogen blockers, that can be challenging for men. They're worried about what that means for them, what that's going to do to their body. And also, how do they explain that to their mates at the pub? Because it's not something that's very common. And I think that there are people out there that wouldn't even know that a man can get a breast cancer. So I think there are some specific challenges, and obviously the communication, understanding, and all of the avenues where they can get information is important. And obviously through our breast care nurses, they can support the men going through this as well.
Yes, no, great. Thank you for that, Lou and John, because it is a topic that's not discussed much at all. So it's good to have that brief discussion on breast cancer.
There is often that stigma. I've got this female disease, and it's hard to talk about it.
Yes, no, it's a good point. Our next question coming in relates to: will the treatment for breast cancer affect my ability to have children? Now, we've already spoken about how the treatments for breast cancer are quite wide and varied, and so I guess the effect on fertility will not be the same for all treatments. But with that in mind, Lou, what are the sort of principles of breast cancer treatment affecting fertility? And then I'll jump over to you, Anne, to talk about how you manage patients and families through a fertility journey in this space.
Yeah, another really important topic for discussion, and super important that we talk to our younger patients who are in their fertile years about this. And we need to do that before they start treatment. So patients that are planning a family or want to keep that as an option, but not only that, patients where we want to preserve their ovarian function if they're very young, and we don't want to put them necessarily into a permanent menopause. So we do have to have those discussions with our patients, and thankfully in most states nowadays we have pretty good access to our reproductive IVF clinics, where we can talk to patients about how we might be able to offer them discussions about fertility preservation. And there's many different kinds of fertility preservation options for our patients these days. That might depend on whether the patient has a partner, their age, all those sorts of things. We also talk to our patients about protecting their ovaries, and we can do that using a medication called Gazerolin, which we may also need to have a discussion about. But essentially what that can do is put the ovaries to sleep so that they don't get affected by some of the treatments that we use. So, for example, chemotherapy, etc. Whilst that does give some menopausal symptoms and side effects, our hope is that when we stop that after the patient has completed the therapy, that their ovaries might awaken and they won't be in permanent menopause, and they're more likely to be able to then become fertile and have a baby and reproduce. I think the other really important information is we've had there's a clinical trial called the POSITIVE study, because it used to be I guess a worry about women, particularly with estrogen positive breast cancer, having children after a breast cancer diagnosis, that might increase their risk of recurrence. But we now have this data to suggest that, in fact, that is probably not true. This study actually looked at women with estrogen positive breast cancer predominantly, who had the initial part of their endocrine therapy in early stage breast cancer for 18 months to 2 years, and then they actually interrupted that therapy to have a baby, and then they went back on the therapy once they'd completed the pregnancy and delivered the baby and breastfed if they could, and there was no reduction in their survival, no increase in the risk of cancer recurrence, and the outcomes for the babies were really good as well. So I think that's super important. And just one other thing, we're actually running a clinical trial looking at this very issue, so fertility preservation with new drugs like immunotherapy. So we're running the Fertile clinical trial, and we're a site here in Hobart where we're looking specifically as to determine whether immunotherapy might affect young patients' fertility, and that's really important in young women with triple-negative breast cancer. So a lot's being done in this space, and it's a super important discussion to have with our patients.
Great. No, thank you, Lou. That's no, very comprehensive. Anne, how do you approach the issue of fertility?
So when I first get a referral from someone in our team for a new breast cancer diagnosis, I always ask them, it's part of my screening, I ask them, you know, if they've got children, if they want children, particularly women of childbearing age. And most of our oncologists are really, really great at addressing this as well. But if I know that someone is going to want to look at fertility preservation, then I work with the oncologist and the oncology team to get a fertility expert involved. As Louise said, there's an awful lot of been a lot of developments in this space. So lots of people stopping various treatments to have a family. There's surgical options, and there's treatment options and things like that as well. And of course, I guess a bit of an offshoot of that is that it's not super uncommon to see people get diagnosed whilst pregnant, which I have definitely seen both as an oncology nurse and also as a midwife. And so that, of course, brings about its own nuances. And there's been a lot of research done into that too in the last 10 or 11, 12 years about, you know, working with the obstetric team as well as the oncology team to treat that mum and that baby.
Sure. No, yes. Thank you. That's another very a special situation that definitely is worth chatting about. Final question that I'll put to all three of you, and whoever would like to answer it is fine. And that's come in about, is it important to recheck the status of a patient's breast cancer, redo the histopathology with another biopsy, more stains, more genetic tests on relapse in case it has changed from diagnosis, or is that not needed?
I might just say yes and hand over to Louise.
Absolutely, and for many reasons. I mean, there are a proportion of patients that start off with a particular kind of breast cancer, and if they're unlucky enough to relapse, it can change its spots. So, for example, it was estrogen positive and then it becomes estrogen negative or something like that. I think the other thing is just because the landscape's changed. You know, in the old days, that if you had a diagnosis, it might have been estrogen positive, progesterone negative, and HER2 negative, but they never told us how much HER2 was on there, which is now really important. So we do like to get more tissue to look at those things, and we get the pathologist now to have a good look at that HER2 and see if there's just a little bit of staining, because that's all we need for some of our new drugs. But also getting new tissue, I think, is important to look for some of these genomic things, you know, looking for certain mutations, PIK3A, ESR1 mutations, all sorts of things which are coming. Some of them are here now and some of them will be here in not so distant future. So we do like, if possible, and sometimes it's just not, you know, it's difficult to get a biopsy depending on where the disease is, but we do like to have another look if we can.
Right. No, great answer.
There's just one more issue. Sometimes it's not breast cancer. And you know, there might be a PET scan that shows something and it's a false positive, or it could be something else. So it's really important just to dot the I's and cross the T's. Yes,
very good point. Okay, we're coming towards the end of our allotted time. I thank everyone in the audience who has watched tonight, and a special thanks to those of you who have submitted questions. As we close up, I'll just go around each panelist to see if there's a closing remark that they would like to give. Starting with you, Anne, and again, thank you for joining us as a breast care specialised nurse all the way from WA. So thank you again, and if there's any closing comments you'd like to make.
Thank you for having me. Yeah, I think the closing comment I would like to make, I mean, there's probably a few, but we could be here all day. But the thing I would like to say is don't be nervous about discussing symptoms with your oncology team, because the only kind of silly question is the one that goes unasked and therefore unanswered. And certainly there's a lot of people still out in the community suffering in silence of something that can be managed quite effectively.
Very good point. Yes, I remember in the early days of the internet, I remember it was sometimes discouraged towards patients and families not to Google their diagnosis, not to look things up, not to write lists for their doctor. But of course, that has long passed, and it's absolutely encouraged for patients, support people, family members to arm themselves with as much education around a diagnosis as possible, write down questions, and as you say, Anne, ask their treating doctor and other healthcare professionals so that it's not unasked. Excellent point. Louise Nott is our Director of Medical Oncology at Icon Group. As I said in the introduction, an experienced medical oncologist who is running Icon Cancer Centre in Hobart. And thanks again for joining us, Lou. Do you have any closing remarks for the audience?
Yeah, thanks, Ian. Look, women and men are living so much longer and better post breast cancer diagnosis these days, and that's thank you to the research that's being done, the patients and families who have been involved in these clinical trials, which enable us to progress and to improve outcomes for our patients. So I guess, my plea is to make sure, if you're listening, to ask about clinical trials and research, find out if there's something being done close to your centre that you might be able to participate in, that might help you, might help others, because it really is the reason that we're making so much rapid progress in breast cancer and other cancers. So that's my little plea.
Like for research. Thank you. And the last word to you, John. Thank you for all you do for Icon, and also you've had such a distinguished career in breast cancer. Of course, as you give a closing remark, I'd also like you to do a second thing, please, and give a plug for your new book, or the second edition rather, of Breast Cancer Taking Control, that is now out, and to tell the audience where they can get a print and ebook copy. But I'll hand over to you for any closing remarks you have, John.
Look, thank you, Ian. And I think in the chat there'll be a link to the book. It's at bcpublish.com on Amazon. But look, just to the audience, life after breast cancer is hard. Life after cancer is hard. I've been through cancer myself 10 years ago. I know what it's like. Every little pain, you worry, but it gets easier year after year. And so the important thing is, remember, don't be afraid to do your own research. Don't be afraid to ask your doctor for a longer consultation. There's more patients in the waiting room, so you've got to manage their time. See what you can ask the support people around them, the breast care nurse, for example. Go into the consult with your top 3 or 4 questions. Don't leave them until you're going out the door. By all means, use AI and ChatGPT and other things to look for side effects, but always understand some AI can get it wrong as well. But thank you for listening, and thank you to Icon for hosting the event.
Yes, no, thank you, John. And look, thank you to all our panel members tonight. Thank you to the audience for watching. As I mentioned at the start of tonight's meeting, there will be a recording on the Icon Cancer Centre website, as well as the Icon Cancer Centre YouTube channel. Please feel free to share the event with friends and family. We'll be having further Icon Facebook Live events during the year. We like to do an event every 2 to 3 months, and we believe it a very important part of what we do at Icon Cancer Centre. So thank you to our panellists. Thank you to everyone watching, and good evening.